This next session is, I'm very excited about this session because it's all about the importance of patient data, and we'll see it from various perspectives. And we have two fantastic speakers. Now, I have to tell you from the start that AJ Potts meant to be here, but given flight issues, he at the last minute had to drop his in-person participation. However, through the magic of our wonderful AV crew, we do have him beaming in. So AJ will be joining us. AJ is from Picker Institute, Europe. And following AJ, we'll hear from Kathryn Huntley from Australia. A few Australians hear this. I love that. That's great. Yeah, and none of them know what day, time, anything is. But I look forward to both. So first, I'd like to introduce AJ again. He works for Picker. Picker's an international charity working across health and social care, established in the U.S. in 1986 and UK in 2000. The work focuses on understanding and furthering the link between patient experience, personal-centered care, and clinical excellence. They use people's experiences of healthcare to identify priorities in delivering the highest quality care, working across health and social care. So, AJ, are you with us?
I am. Thank you, Peter. Can you hear me?
I can hear you very loud and clear. I can see you down there. Are we going to see him here? Oh, he's over on the side. I see. There you go. Wave at everybody, AJ.
Hi, everyone. Thank you.
There we go. They're waving back.
I will take your word for that, Peter. I can't see anyone, so.
I will let you take it from here, AJ. Thanks very much for doing this for us.
Oh, no, thank you. Very much appreciate it. And thank you to the AV team as well. I presume I have control and you're seeing my slides now. Could someone confirm that the slides are what I'm expecting?
Yes.
Brilliant. Thank you. Sorry, I can't see that. So as you heard, my name's AJ. I'm sadly struck off from being in attendance by KLM strike action. So thank you for having me this way. I won't introduce Picker again because Peter did a really good job of doing so. So thank you so much for that. But if you do want some more information about who we are and what we do, our website's there. We've been working with CLLAN now for a number of years, and I'm really pleased to join you again for the second time in 2 years. So moving on to why we're all here today, or I am at least anyway, is to talk about why the patient voice matters. Now, you all know that the patient voice is powerful. It brings context, emotion, and urgency. The patient is, of course, the only person going through the entire treatment process. When we combine voices into data, when we collate those experiences, we can advocate more effectively for change in care, policy, and research. And data allow us, of course, to identify patterns, to highlight differences, and make compelling cases to clinicians, to researchers, and policymakers. It's not good enough just to collect data. We need to use data to inspire change. And Ben talked earlier about having informed patients. Here we're going to talk about how patients can inform others. And it's our job to use that, our platform, to amplify that voice. So, how are we going to do that? Broadly, there are 4 steps to gathering and using data. Each of those steps has more to do in it, and I cannot possibly cover all of it now. So this is a high-level overview. The most important thing you need to do is to think about what you need to know and what your end use for the data will be. Is it going to be a graph, a report, a presentation, a conversation such as this? Oddly enough, starting at the end will make you have a better use of the data at the far end of it all. Next step is to design a data collection, either from existing data that are out there, why reinvent the wheel after all, or new sources if in fact the wheel has yet to be invented. Make sure you're asking the right questions and test them out. After doing that, interpret the data that have been collected. Use the appropriate methods. Look for patterns and unmet needs, and I'll touch on what those methods are in the next couple of slides. And as I said before, most important step of all, use the insights that you gain Advocate for change, design tools, publish your findings, inform policy briefs, make a nuisance of yourself in stakeholder meetings, go to hospitals, go to GPs, go to whoever it is that you need to, and make the voices heard. That is the whole point of the day today. So, how do we get those data then? Broadly, again, there are two methods. The first is words, qualitative methods, focus groups, interviews, story collections. These methods provide us deeper insights from a smaller number of people. In terms of analysis, last year I took you through some of how to do this. The use of thematic analysis is really quite common. That's where you find repeated mentions of the same topic in the dataset and describe the feelings attached. More sophisticated methods here will use different lenses and theories to pull apart the findings in great detail. Overall, qualitative methods are really valuable in their own right and can be used to develop topics that you will explore with a greater number of people in the other type of data, which we're going to come to next. When you're dealing with qualitative data, the most important thing you can do is think about the questions you're going to ask people. Do they make sense? Do they ask what you need? And then crucially, amplify the voice. Let the qualitative data speak for themselves. It's not your job to impose a view. It's your job to use this data. The other type of data then, numbers, quantitative data. In terms of patient data in particular, what we're often looking at here is typically online surveys or paper-based surveys to measure experiences, things like Google Forms, Microsoft Forms, SurveyMonkey. These methods tend to represent the experiences of a wider number of people, usually in less depth. And what I would say here for any questionnaire design that you can ever possibly do, keep it as short as you possibly can. Ask only what you need to know, not what you think you might like to know. That can be a future study, a future ask. In terms of analysis, you're going to use descriptive statistics like averages, means, medians, the maximum, the minimum. And you'll use things called inferential tests to compare groups, such as the t-test and chi-squared test. More sophisticated methods will use things like regression trees, or regression models or decision trees to make predictions about those data. And these quantitative methods are useful in their own right and can identify areas that you might want to explore in more detail with fewer people. Think hard about the output you need and think about whether people will understand it. We had a few conversations about having people talk to each other. Should the doctor be changing their language or should the patient be upping their game? It's a bit of both probably, and in no way should anyone necessarily be forced to be a statistician. It's full of awful terms that nobody really likes to talk about and have dreadful conversations around things like heteroscedasticity. It really doesn't matter. The point here is actually translating the data into use, right? Looking ahead as well, just briefly touch on this, is to say that I see some really exciting possibilities of the use of tech. We've heard of AI. You do need to be cautious with it. It's not a magic bullet. But tech itself, it can help patients become co-creators of research. And we're moving towards models where data isn't just about patients, it's owned and driven by them. Crucially, though, it's been said a few times already, we all need to continue to talk to each other. It's not about the tech. The tech is just an enabler. It's not an end in itself. Moving on to the next part. So challenges and considerations then for using data. Crucially, we must use it responsibly. We must ensure that all voices are heard, especially those from underrepresented communities, so that we collect and use data ethically and that we amplify the voices as they should be. We at PICA have recently released a taxonomy of underrepresentation, so where people's voices are systematically not heard. And we've given a toolkit in part of that release that can help you identify in your data whether you might have that risk of not hearing some of the voices that you want to be hearing from. We need to be mindful as well, of course, of how often we ask patients to share their stories and how often we are amplifying those stories. We don't want people to be getting fatigued either side of that. You don't want to hear the same story repeatedly, and you don't want to be telling your story repeatedly. Just before the break, of course, we heard from Rita, Cindy, and Oliver here talking about how language evolves and how we're talking to each other. we want to make sure that we're using the data in the right way. When we're talking to academics, perhaps we want to talk more detail about the methods. Perhaps we want to use more complicated languages. For policy makers, maybe we just need the take-home messages, or maybe again it's a blend of that. We shouldn't just be blinding each other with terminology. We should be thinking about the message and the story that we're wanting to tell here. There's a lot to talk about in terms of the visualization of data as well, and that's way beyond the scope here. But a graph is not just a graph. There are good and bad practices there. And the most practical tip I can give you on this one is, again, thinking back to the end use. What is it that you want to be conveying as your message? Make sure your visualization shows that. So in terms of actually advocating then, what does that look like? Some of you are obviously doing that already. Just sort of give you a hint as to how PICA are doing it. We collect probably the world's largest workforce survey in the National Health Services staff survey. There are around about 1 million respondents to that. We manage that one. So how do we make use of that? Well, typically we typically try and leverage into the national policy consultations. And where we do that, we include data from those surveys, and we use case studies from our Patient Experience Network Awards. So we've got the sort of formal input to these big, broad policy consultations. You submit reams and reams of paperwork. But there's other ways we can influence decision makers and advocate for people as well. Peer-reviewed publications to interest the scientific community, press statements, blogs to hit the more general public. And as I said before, making a nuisance of ourselves in local hospital boards. A number of conversations I have with hospital CEOs and directors of midwifery and directors of nursing staff generally, the head consultant teams. That's where you can get some real traction, and I definitely relate to that one. You can find more of this on our website here, and to give you a concrete example of how we're doing that, though, with regard the recent response to the UK National Cancer Plan, there are a few abbreviations here, and I'll do my best to avoid them. And in fact, that is a top tip. Try to avoid abbreviations at all costs unless they're really, really well known. So the NHS in England, at least, you can use that without defining it, but everything else you really ought to define when you're talking to people. Don't assume they know the abbreviations of your language just in case. In this particular one, and you can read the full submission, we used a real mix of hard facts. The most recent NCPES data, so the National Cancer Patient Experience Survey data, published in July 2024, shows a reduction in the number of patients reporting the length of time that waited for diagnostic testing felt right, 77.6%. All right, so hammering home the hard fact. We also then highlight the qualitative data here as well. A participant noted guidelines in their response, very long waits, 3 times longer than NICE guidelines for test results, surgery and chemotherapy start date. Also up to 3 hours to see the doctor. So we're showing that they know abbreviations. We're showing that they happen to know what should be happening. They know what the guidelines are. And we can amplify that. You've heard about this one already a few times, and I presented some of it last year. Just to advertise it to you all again. Really powerful example of this. We had such a great response here, over 800 people from 30 countries with CLL responding, and it highlighted critical issues like diagnostic delays and access to treatment, insights that are shaping advocacy priorities. I'm not going to rehash all of it here. Instead, head to the report if you haven't already. But the crucial thing is that it gives evidence that can be taken, for instance, towards the immune compromised task force, also to your own organizations as places to start. We're also in the midst of submitting for a peer review publication to get this out into the scientific community as well. My final point here is just to say, let's keep listening, let's keep learning, and keep using data to make the CLL journey better for everyone so that we can learn, share, and grow. I'd just like to say again, thank you very much for listening to me and for everybody who's been supporting me to be there remotely. Thank you very much. So then.
Is it just me, or did anyone else notice that AJ used AI for some of those photos? Thank you, AJ. That's very informative, and please stay around for questions, of course. And
absolutely.
I would like to invite Kathryn to come to the stage, and well, she's at the stage, but to the mic. And Kathryn, I imagine you have some examples to speak of with the work with CLLAN, and that's okay, because we use data extensively, and Kathryn's become one of our in-house gurus.
Hopefully there's some slides of mine that are here as well. Do we have those ones? Okay. So I guess what I took out of this, and it's always hard to follow AJ. I learnt that last year when he was here with us in Barcelona at the time. And I guess what I was sort of taking on board is, AJ has spoken a lot about, the surveys and that lived experience through surveys, and that there are different ways, which AJ sort of tapped a little into around gathering those insights from the lived experience. What we've also seen, and we saw Professor Stephen present a lot of data in that quantitative format, I should say. But what does that actually mean? And I guess for me, lived experience, as I said, has shown here, gives us the why. The data gives the what. A lot of people in this room are living the experience, and the data comes as no surprise to them. So how do we bring the expertise of living with CLL to enhance those data insights to make real change in our community? So I guess, what we've got here is the lived experience fills the gap in the data. Now I know why the mic was used before. It's a bit tricky because I've also got AJ's head down there, which isn't a bad thing, AJ, but I don't see my own slides. So I might use this, thank you. So what data may not, and what we may not see on the graphs that were presented by Professor Stephen before was, what is the actual quality of life? And as Cindy beautifully told us, her own definition of quality life, what is underneath what that means to someone. And Brian mentioned it before, that, for someone, people might say, oh, they're 84, they've had a good innings, is what, very non-compassionately might get said to them. But what is taken from their life as far as things like growing up and seeing their grandchildren, what is important to a person in their life isn't seen in a graph, but it is in a person's story. The emotional burden that sits behind those pieces of information that are out there, the health inequities, as alluded to. It's nighttime, I should be asleep from where I was, and I was only left there about 30 hours ago. But something I learnt recently, which was really informative to me, and something that I hadn't really thought about in sort of the 25 years I've worked in this space, was, in Australia, we have a diverse geographical country that we live in. So there's inequities for patients that live, and I personally lived a 10-hour drive from our state capital, and the local hospital that wouldn't be able to treat me for CLL was at least 3.5-hour drive away. So while that may see as a barrier to treatment, the person next door to me might have had very different barriers. So as a rural person, we are not all the same. So I guess an example of what this looks like, which I've sort of alluded to then, my postcode didn't actually define who I was, but my story when I lived in the little town called Springshaw was I was okay because I actually had family in Brisbane. So if I needed treatment, which I actually did when I was quite little for something very completely different, we could drive down because I had physically fit parents to do that and a mother who wasn't working, and we could stay with family, so costs and transport weren't an issue. But for my neighbour who had a farm to run, they couldn't just leave the property. I won't speak too much in here because AJ sort of spoke to this a fair bit, but I guess what I wanted to hone in on is when AJ spoke around bringing those qualitative points in, around, inter-policy briefs and that sort of thing, how it then, and I think you did speak a little bit to this, AJ, around the, 80% of patients reported delay in diagnosis is far more impactful than a single moment. And I know, sorry, I keep picking on Cindy, but she had some really great points in her messaging today. And I know in Thailand, like it's unfortunately a growing incidence community, but how, when incidence is low, can you amplify the need of a patient community? And what we've seen in Australia is a groundswell of a rare cancers organisation. So when there was small numbers, they came together as an aggregative unit to actually then talk about the impact that it was having, and having then the numbers to speak and be listened to from our local parliament. AJ spoke a little bit about this as well, and it's about blending the lived experience with the patient voice. And this is something that I know in my previous role, and we see in a lot of patient organisations, when you're going to have that cut through, and sometimes, as Professor Stevens spoke about earlier, we are quite fortunate in Australia compared to many countries around the world with having access to the drug, but that doesn't happen unless we have our patient advocates there in present talking about their lived experience. Before we can get them in front of the right people to share their story, there's papers and, working with our local pharmaceutical to get approval of drugs. And sometimes we can use the lived experience. So further to the 80% of people, or we're talking about this is the number of people, we can then say, while, 1,200 patients have this in our country right now, we're going to share John's story. Bearing in mind, I was thinking of Brian, it is one person's story, but in these moments with the right alignment of a person's story to what the ask is, it has really great cut through. Something that's really important to me as I stand here as a health professional and not as someone who lives with a CLL diagnosis. Co-creation is key. Actually understanding what we're seeking in the first place from those living it is really important. Something that I've learned over time, and back in 2015 did one of the processes that AJ spoke to with the one-to-one interviews, where we went with very open-ended questions, and importantly, learnt so much by leaving our own agenda at the door. We weren't thinking about what we wanted to change. We truly wanted to hear, tell me about what it was like for you. And what did that mean to you? And then from there, we went through that thematic analysis to actually try and understand what were those key commonalities from a very different, diverse group of experience that we could then attack. So I guess when we are looking at that lived experience and something that we do, it's around making sure we can build that trust. We have that credibility, and importantly, that we're talking the language that makes sense to the people in front of us. Speaking of Johannes's work in the clinical trial space, if I went in there and spoke as a health professional with the mumbo-jumbo language, I'm going to lose people straight away, or they're not going to feel like I can understand them in return. Asking the right questions, whether it is through surveys, focus groups, or those one-to-ones, knowing sort of the best forum to actually get that information. If you want to, get sort of a very with our patient lived experience surveys, there's ongoing questions that we ask every time to actually see whether anything we've done is actually making a shift in the dial of what's going on. If we wanted to sit down because we wanted to learn a lot more about, the impacts that immunotherapy is having on people, or when we again, with that sort of, it was mentioned earlier, what matters to people when they're actually deciding on treatment. We can make a lot of assumptions, but if we sit down and ask those questions, we can learn a lot more. Making it accessible, which you see that we do with our global surveys. They are online, which obviously can be a limitation for some people, but they're in a multitude of languages, trying to address some of those barriers. As AJ mentioned, trying to keep it short and sharp is really, really important, because you will lose people over a lengthy survey. Mixed methods, I should say, for richer insights. So combining those qualitative and quantitative moments for a complete picture, a complete story of what's going on in the community that we serve. something that I think, and AJ mentioned it around the survey fatigue, something that I think we need to get a lot better at as a collective community is closing the loop. We asked you, you told us, then we did, and now we want to know if that's made a difference, is sometimes a better way to make the survey, but also validating a person's time. People can often share quite intimate and personal moments about their own experiences, and we should respect that by sharing that journey with them and going back and closing the loop of what their story meant to us and how it's made impact for the generations to come. And as I sort of said, number 6 is here, but it's actually my most important, that it isn't just a tick box. And so what does that look like in actually having a true partnership and not just a tick box? I'm not going to go around, again, AJ sort of spoke to this, but I wanted the last point about thinking about the role that lived experience plays, not just in your organisational activities, so completing surveys or helping lobby access to a drug, but informing your activities. So even going, into that first place of when you're trying to work out who you are or what activities you should be doing, actually asking the community, what does that look like? Or when you are developing what your plans or projects are going to be, making sure you're checking back with your community or having some key lived experience people to look it over to make sure that what you think you knew, or as Brian was mentioning earlier today around, what was told at one point, or that the reality of information that's online is outdated as quickly as you develop it. So making sure that the information that you had when you started trying to work out where you were going is still actually reflective of current need. And I think that's me.
Well, as you can see, very good presentations from both speakers. There he is. Hi. AJ's back. Are there any questions from the floor? We have a question up front here. Whoever's running the microphone.
Thank you very much. Can you hear me, AJ?
Can you hear
can't hear you,
We
though.
can't hear you now.
Yeah.
There
yeah,
we go.
Just about.
There we go.
So I'm gonna address this to you, but if you want to chip in too, we're always told to make these surveys short. But when I talk to patients, I say, look if it's really applicable to you. So I have to ask male or female, then I have to ask their age, then I want to ask their ethnicity, right? That's important. Then I want to ask if they're relapsed or refractory or first-line therapy. Do I need to start over?
No, I caught it. That's fine.
Yeah. I'm 5 or 6 questions into it to define what population of CLL. Again, maybe this is a first world problem, but you want to make sure that you're asking the right question to the right group of CLL patients. Very difficult. A 30-year-old female with CLL than an 80-year-old male who's, treatment naive, so you have to know this stuff. I'm 6 or 7 questions in before I've even asked them how long have they had their CLL. Help me with this.
AJ, I have a little part, but then I'm going to throw to you from more of that global asking when you're in an external group. So a way that I've previously got around that is, unless it's externally promoted, and sometimes if you're promoting to your own known group, those questions become a lot easier because you can actually, there's survey technology where while it's, I guess, de-identified to the level, it actually pulls that information. So we've got software nowadays that's smart enough that if I send something to Brian, because I have Brian's details in my, database, it's actually pulling those precursor questions that help with those other elements of understanding, age demographics and, location and those sort of things. So you then can actually cut through to the questions that are specifically around a person's experience. But that's when it's a known population, and sometimes just asking the people that you already know is always going to give you a very, a non-representative insight. But AJ, how do you work around in that space?
Essentially exactly the same as you say there, Kathryn. If you've got a known population, you can link it in the background and do away with those questions. Although from experience with our patient surveys in UK, Some of the hospital data warehouse data that you would populate those with are not what the patient tells you they are, particularly around ethnicity. So not just not stated being a kind of default position, but actually people will have been misassigned in some instances. So yeah, there's no silver bullet to it. I think if you've got an unknown population, sometimes you're just going to have to take it on the chin that you're going to have 7 questions at the front of your survey.
And I think it's prefacing those questions with that content, like why am I asking you this, which I've done historically as well, so that somebody understands it, that especially if they're known to the organisation, it can feel a little bit insulting to be asked the questions that you know that you've already shared previously. But to a more broader group, it can go, we're asking these questions because it can help inform sort of that advocacy action.
Yeah, absolutely. And that is actually one of the points we make in the paper I mentioned about the underrepresentation. If you don't collect that data, how can you possibly ever provide evidence to that group? So yeah, it might unfortunately make your surveys longer, but hopefully makes them better as well. So.
Very good. Is there another question out there? I can't see. Are there anything else? Okay, well, AJ, Kathryn, I want to thank you very much. It's very insightful. And I want to send everyone again to our various survey results and reports that we have on the CLLAN website. You'll have a lot of insight on how these surveys are put together, all the qualifications, and just you get the full picture and you get to understand how deeply detailed to do this right it is. So thank you again, you two.
And I guess, Peter, just as
Of course.
AJ very quickly touched, we're in the process of submission of our last survey for an academic paper. So we will share those news when hopefully it gets picked up and published for, to AJ's point earlier that, it's another way to make sure that that advocacy message and the lived experience gets out there. And hopefully, people then leverage our insights for their own research to broaden the messaging too.
Very good. Thank you.